This conference will now be recorded.
Today's topic is septic shock and pathophysiology and management. Shock is a clinical syndrome that results from inadequate tissue perfusion. Types of shock are hypovolemic shock, cardiogenic shock, obstructive, distributary, and endocrine shock. Septic shock comes under distributary shock. Bacteremia is the presence of bacteria in the blood as evidenced by positive blood culture, whereas septicemia is presence of microbes and their toxins in the blood. Systemic inflammatory response syndrome includes any two of the following: fever more than 38 or less than 36 degrees, tachypnea more than 24 breaths per minute, tachycardia, heart rate more than 90 beats per minute, or leukocytosis or leukopenia more than 12,000 or less than 4,000. When the systemic inflammatory response syndrome can be because of trauma, burns, or sepsis. We call it sepsis when SIRS has been proved with microbiological etiology. Severe sepsis include one or more signs of the organ dysfunction as given below. Cardiovascular arterial systolic blood pressure of 90 mmHg or mean arterial blood pressure of 70 mmHg, which responds with IV fluids. When this does not respond with IV fluids, then we call it as septic shock. Renal When urine output is less than 0.5 ml per kg per hour of 1 hour, despite of adequate fluid resuscitation. Respiratory rate is partial pressure of arterial oxygen by fractional inspiratory oxygen of 250, or if lung is the only organ, dysfunction of 200. Then this ratio we consider as 200. Hematological platelet count should be less than 80,000 or 50% decrease in the platelet count from the highest value recorded in previous 3 days. Unexplained metabolic acidosis when pH of 7.3 or base deficit of 5 milliequivalents per liter and plasma lactate level more than 1.5 times the upper limit of normal. Even with adequate fluid perfusion resuscitation, the pulmonary arterial blood pressure of 12 mmHg or central venous pressure of 8 mmHg. Septic shock, sepsis with hypotension, whereas systolic blood pressure of less than 90 or normal less than 40 mmHg of the normal patient's blood pressure of at least 1 hour despite of adequate fluid resuscitation or need of vasopressor supports to maintain the systolic blood pressure more than 90 or mean arterial pressure more than 70 mmHg. The refractory septic shock is the patient doesn't respond with fluid or vasopressor, then we call it as refractory septic shock. Multi-organ dysfunction. The dysfunction of the more than one organs requiring intervention to maintain the homeostasis. Systemic inflammatory response syndrome is because of trauma, burns, or sepsis. Sepsis can be severe sepsis, or the patient may go into shock. It might be because of parasites, virus, fungus, and bacteria. Most common is the gram-negative, which accounts about 70%, and gram-positive is the next most common. It can be because of virus, fungus, or parasites. When the patient comes with sepsis, we should look for the site of infection. Measure is IV. If the patient is having IV cannula, we should look at the IV cannula site for any erythema swelling. It is suspected if the patient develops evidence of sepsis and the line has to be changed for more than 4 days. In case of lungs, the high risk of nosocomial pneumonia in intubated patients after being in ICU for more than 3 days, particularly if treated with antibiotics, the nasopharynx become colonized with gram-negative bacteria, which migrates to the lower respiratory tract. In case of abdomen, we should look for any intra-abdominal abscess, necrotic gut, or any previous abdominal surgeries, pancreatitis, acute cholecystitis, and perforated peptic ulcer. Urinary tract, a relatively unusual source. We should also look for heart valves, meninges, joints, bones, nasal sinus, ears, and retropharyngeal space and urinary tract. The pathophysiology of shock. It is result from the host innate immune response to infectious organisms that may be bloodborne or localized to particular site. Gram-negative bacteria accounts 70%, which is because of endotoxins, whereas gram-positive is because of exotoxic shock. It is because of lipopolysaccharides. It is because of exotoxins. The lipopolysaccharides are present in the cell wall of the bacteria of the gram-negative response for the septic shock for warming of the cytokine response. Lipopolysaccharide is recognized by toll-like receptor 4 in combination with MD2 and CD14. LPS binds with the body fluids and bound to the acute phase proteins like liposaccharide binding protein, and which is recognized by the CD14 on the surface of the fibrocytes, and having bound with LPS and CD14 interacts with the toll-like receptor 4, resulting in the activation of the NF alpha B in the nucleus. When these two bonds and activates the CD14, which releases the interleukin 6, interleukin 1, TNF alpha, and platelet activating factors. The lysis of gram-positive bacteria will lead to peptidoglycan fragments and lipotecoic acid, which is recognized by the toll-like receptor 2 and 6 on the macrophage, and this causes transcription. And this releases the cytokines, and this causes the activation of the coagulation factor and the prostaglandins release and activation of complement pathway, which causes blood clotting, inflammation, and endotoxins binds to lipopolysaccharide binding protein on the macrophages, which leads to interleukin activation of the tumor necrotic factor, interleukin 1, 2, 6, 8, 12, and interferon alpha and platelet activating factor. This causes hypothalamus, which lead to fever, stimulates hypothalamus, which lead to fever, tachycardia, and tachypnea. And capillary endothelial cells will also get damaged, which causes leakage of the fluid and activation of the platelet adherence, neutrophil migration, which finally lead to disseminated intravascular coagulopathy with clinical thrombosis and hemorrhage, this duplication of intravascular volume. And there will be nitric oxide release, which causes vasodilatation and which finally leads to the cellular hypoxia and low systemic vascular resistance and toxic oxygen radicals, which will leads to lactic acidosis and multi-organ dysfunction, which finally leads to death. Clinical features of shock. Because of bacterial endotoxin, there will be leukocyte activation, and this causes massive cytotoxin release, which affects the liver synthesis, and liver produces the factor 2, 7, 8, 9, and 10, and this causes coagulopathy and widespread complement and coagulation cascade activation, which utilizes the coagulation factor consumption and which leads to disseminated intravascular coagulation. This also leads to microvascular damage and causes acute renal failure and decreased renal function due to direct cytokines effects, which lead to acute renal failure. And because of impaired metabolites, it also impairs the cardiac contractility, which causes hemodynamic collapse. And it also causes diffuse cerebral dysfunction. Because of massive cytokine release, there will be febrile response by activation of hypothalamus, increases the whole body metabolic rate, which leads to hypoxic respiratory failure, and also acute lung injury, the vasodilatation and increased capillary permeability, which causes pulmonary edema and acute lung injury and leads to hypoxic respiratory failure. Hyperventilation is the early sign of septic response. Disorientation, confusion, and other manifestations of encephalopathy may also develop early on, particularly in the adults. Hypotension and disseminated intravascular coagulopathy predisposes to acrocyanosis and ischemic necrosis of most commonly the disease. Cellulitis, pustules, bullae, and hemorrhagic lesions develop because of hematogenous bacteria and fungi, seeds in skin and underlying soft tissue. Bacterial toxins may also distributed hematogenously and elicit diffuse cutaneous reactions. On occasion, skin lesions may suggest specific pathogens. Cutaneous Petechiae purpura is because of Neisseria meningitis, and patients bitten with tick. While in the endemic areas, we should suspect rock mountain spotted fever. A cutaneous lesion seen almost exclusively in the neutropenic patients. Ecchymosis granulosum is we should suspect Pseudomonas aeruginosa. In case of hemorrhagic or bullous lesions in septic patients, we should ask the history of recent eaten raw oyster suggestive of Vibrio vulnificans bacteremia. And generalized erythroderma in septic patients suggests the toxic shock syndrome due to Staphylococcus aureus and pyogenes. Gastrointestinal manifestations. In case of acute gastroenteritis, patient will present with nausea, vomiting, diarrhea, ileus. In case of hepatocellular canalicular dysfunction, we should suspect the cholestasis jaundice. There will be elevated serum bilirubin and alkaline phosphatase, and that appears underlying most cases and the result of hepatic dysfunction test and return to the normal with resolution of the infection. The prolonged and severe hypotension may induce acute hepatic injury and ischemic bowel necrosis. Many tissues may unable to extract oxygen normally, which leads to anaerobic metabolism despite of normal mixed venous oxygen saturation. Blood lactates raise earlier because of increased glycolysis as well as impaired clearance of resulting in lactate and pyruvate by the liver and kidneys. Blood glucose concentration often increases, particularly in the patients with diabetic, although impaired gluconeogenesis and excessive insulin release on the occasional reduce hypoglycemia. The cytokine-derived acute phase response inhibits the synthesis of transthyretin while enhancing the production of C-reactive protein, fibrinogen, and the complement components. Protein catabolism is often markedly accelerated. Serum albumin levels declines as the result of decreased hepatic synthesis and movement of albumin into the interstitial spaces. There are cold shock, warm shock, and cold shock. Warm shock is it's a reversible stage, whereas cold shock is irreversible. And in case of warm shock, there will be pyogenic response is intact, whereas in case of cold shock, the pyogenic response is lost. The inflammatory response and in case of warm shock, the inflammatory response presents with fever, tachycardia, and tachypnea. The patient, when treated properly in warm shock, will be reversible, and we can save the patient. In case of cold shock, if it is irreversible stage, so the patients will go into multi-organ dysfunction syndrome with anuria, respiratory failures, jaundice, cardiac depression, pulmonary edema, hypoxia, drowsiness, and eventually coma and death occurs. Complications, cardiopulmonary complications. There will be mismatch in the ventilation perfusion, and which leads to the decrease in arterial partial pressure of oxygen, which causes the increases the alveolar epithelial injury and capillary permeability, which increases the pulmonary water content, and this leads to pulmonary edema and decreases the pulmonary compliance, which progresses diffuse pulmonary infiltrate and arterial hypoxemia. This leads to acute lung injury, and if it is not treated properly, it will lead to more severe hypoxia with a ratio of less than 200, partial pressure of arterial oxygen and fractional inspiratory oxygen, which denotes the acute respiratory distress syndrome. An elevated pulmonary capillary wedge pressure, more than 18 mmHg, suggests the fluid volume overload or cardiac failure. Sepsis-induced hypotension usually result initially from sepsis-induced hypotension usually resulting from the diffuse capillary leakage from intravascular fluid or dehydration from the ascendant disease or insensible fluid losses like vomiting, diarrhea, and polyuria. In case of early sepsis, there will be cardiac output will be low and systemic vascular resistance will be elevated. After fluid resuscitation, there will be, in case of septic shock, the cardiac output will be increased and there will be decrease in systemic vascular resistance. If this does not occur, we should suspect other types of shock. Other processes that can produce this combination are anaphylaxis, beriberi, cirrhosis, and overdose of nitrofuranide and narcotics. Depression of myocardial function manifests as increase in diastole or systolic ventricular volume with decreased ejection fraction and develops within 24 hours in most patients with severe sepsis. Cardiac output is maintained despite the lower ejection fraction because of ventricular dilatation permits a normal stroke volume. In survivors, myocardial function returned to normal over several days. Refractory hypotension is usually due to the low systemic vascular resistance. Death results from the refractory shock or failure of multiple organs rather than from the cardiac dysfunction per se. In case of bacteremia and endotoxemia, there will be nitric oxide synthesis, which causes vasodilatation, and this causes arterial underfilling and baroreceptor activation. This is detected by the brain by cardioregulatory center, and this causes increased sympathetic tone. This increases the renin-angiotensin synthesis, and this causes renal vasoconstriction with sodium and water retention. Renal complications are oliguria, azotemia, proteinuria, and non-specific urinary gas syndrome are frequently found. Many patients are inappropriate polyuria and exacerbated with hyperglycemia. Sepsis and endotoxins activated by protein C causes disseminated intravascular coagulopathy. This causes clots in the blood vessels in the glomerular, and this lead to acute renal failure. And hypotension and increased catecholamines and vasopressor resistance to norepinephrine and angiotensin II causes renal ischemia and finally lead to acute renal failure. Acute tubular necrosis induced by the hypotension and capillary injuries, and glomerular nephritis and renal cortical necrosis and interstitial nephritis. Coagulopathy. Because of endotoxin, there will be activation of the coagulation cascade, which causes the fibrin, thrombin, and fibrin activation, which leads to fibrin clot formation. This utilizes all the coagulation factors, platelets. So the platelet count will be very low, less than 50,000. In the patients with disseminated intravascular coagulopathy. Neurological complication. When septic illness lasts for weeks or months, the critical illness, polyneuropathy may prevent weaning from ventilatory support and produce distal motor weakness. And electrophysiological study is a diagnostic for this. Immunosuppression. Because of loss of delayed type of hypersensitive reaction to common antigens, failure to control the primary infection, increased risk of secondary infection, and appropriate 1/3 of the patient experience the reactivation of herpes simplex virus, varicella zoster, and cytomegalovirus infections. Adrenal insufficiency due to reversible dysfunction of hypothalamic pituitary axis and tissue corticosteroid resistance resulting from abnormality of glucocorticosteroid receptor or increased conversion of cortisol to cortisone. The major clinical manifestations are hypotension, that is refractory to fluid replacement and required pressor therapy, and hyponatremia, hyperkalemia, eosinophilia, and hypoglycemia. For laboratory findings, when there is infection, there will be leukocytosis. And when the liver is not affected, there will be hyperbilirubinemia, proteinuria, and azotemia. And there will be elevated aminotransferase. And microangiopathic changes also seen in the blood smear. Thrombocytopenia because of coagulopathy, and prolonged thrombin time, and decreased fibrinogens because of utilization formation of clots, and presence of D-dimer suggests of disseminated intravascular coagulopathy. Neutrophils may contain toxic granulations, Dowley bodies, and cytoplasmic vacuoles. Arterial blood gas reveals hypoxemia. Initially correctable with supplementary oxygen, but later refractory to 100% oxygen inhalation indicates the right to left shunting, and metabolic acidosis and respiratory alkalosis. The chest radiography may be normal or may show evidence of underlying pneumonia and volume overload or diffuse inflammatory acute respiratory distress syndrome. ECG should be done to look for sinus tachycardia or non-specific ST wave abnormalities. And we should, in case of sepsis patient, there will be hyperglycemia. Blood sugar should be monitored frequently, and we should treat accordingly. Severe infections may precipitate the diabetic ketoacidosis if not treated. Serum albumin levels will be declined because the liver functions are not synthesis is decreased, and there will be shift of the albumin into the extravascular spaces, and there will be hypercalcemia, but it is very rare. Diagnosis. There is no specific diagnostic test for septic response. Diagnostic response is suspected in Crohn infection, like we should look for fever when the patient is having tachypnea, tachycardia, leukocytosis, leukopenia, acutely altered mental status, and thrombocytopenia. And there will be elevated blood lactate levels and hypotension. This SOFA score. SOFA is a sequential organ failure assessment. We should assess the organ failure depending upon this score. This is a scoring system that assesses the performance of several organs in the body. The higher is the SOFA score, higher chances of morbidity also will be in mortality and morbidity will be increased. It will take a longer time. When the patient comes, immediately we are doing Q-SOFA, which is a quick SOFA score, quick sequential organ failure system scoring, which consists of only will look for mental status of the patient, respiratory rate, and blood pressure. If it is each is given one point, and if it is more than two, the higher is the chance of mortality. In case of SOFA, the respiratory will look for partial pressure of arterial oxygen, fractional inspired oxygen. Each when it is more than 400, the point score is given as 0. Less than or equal to 400, score is given as 1, and less than or equal to 300, score is given as 2. Less than or equal to 200, score is given as 3. Less than or equal to 100, score is given as 4. Renal creatinine, which is less than 1.2 or 1.2 to 1.9, score is given as 1. 2 to 3.4, score is given as 2. 3.5 to 4.9, and urine output of less than 500 ml per day, score is given as 3, and more than 4.9, and urine output of less than 200 ml per day, score is given as 4. In case of liver, we will look for bilirubin. When it is less than 1.2, score is given as 0, and 1.2 to 1.9, score is given as 1, 2 to 5.9, score is given as 2, and 6 to 11.9, score is given as 3, and more than 11.9, score is given as 4. Cardiovascular, we look for hypotension. There is no hypotension, score is 0. When mean arterial pressure of less than 70 mmHg, score is 1. And patient is on dopamine or dobutamine of less than 5 dose, then score is given as 2. And dopamine more than 5, and epinephrine less than or equal to 0.1, or non-epinephrine of less than 0.1, then score is given as 3. When it is more, score is given as 4. Hematological platelet will look for platelet count. When it is more than 1.5 lakhs, score is 0. And when it is less than 1.5 lakh, score is 1. When it's still less than 1 lakh, score is 2. Less than 50,000, score is 3. Less than 20,000, score is 4. Neurological changes, we look for Glasgow Coma scale. When Glasgow Coma scale of the patient is 15, score is 0. When it is 13 to 14, score is 1. And 10 to 12, score is 2. 6 to 9, score is 3. Less than 6, score is 4. So higher the score, likely the morbidity will be increased. Definitive etiology of diagnostic require isolation of the microorganism from the blood and local site. We should isolate from the blood to prove or any local site to prove if the patient is having sepsis. So we should collect 2 blood samples from those 2 different venipuncture sites. Likely we'll collect from left and right half brachial veins. And in case of patients with indwelling, already having indwelling catheter, one sample will collect from that and another will collect from venipuncture. If the blood culture is negative, we should not think that patient is not on sepsis. It may be because of prior antibiotic administration or presence of slow growing fastigious organisms or absence of microbial invasion of bloodstream. And in these cases, gram staining and culture of material from the primary site of infection or from infected cutaneous lesions may help to establish the microbiological etiology. We can also identify the microbial DNA in case of a polymerase chain reaction. And we should check for skin and mucosa should be examined carefully and repeatedly for lesions that might lead to diagnostic information. With overwhelming bacteremia, like pneumococcal sepsis, in case of a spinactized individual, fulminating meningococcal or infections with Vibrio malificans, microorganisms are sometimes visible in buffy coat smear on the peripheral blood. Treatment. The successful management requires urgent measures to treat the infection and to provide hemodynamical and respiratory support and to eliminate the offending microorganisms. Measures should be initiated within 1 hour of the patient presence with severe sepsis or septic shock. We should give the broad spectrum antibiotics first and then we should send for culture and we should change according to the culture report. Antimicrobial agents. Combination is not superior to monotherapy in case of gram-negative bacteremia. Only exception is Pseudomonas aeruginosa, which is less effective than the aminoglycoside. Monotherapy is less effective when compared to the aminoglycosides combination therapy with anti-pseudomonal lactam agents. Empirical antifungal therapy should be strongly considered if the septic patient is already receiving broad spectrum antibiotics or parenteral nutrition has been on patient parenteral nutrition and has been neutropenia for 5 days and has had a long-term central venous catheter and has hospitalized in the intensive care unit for prolonged period. Immunocompetent adults, we should think of piperacillin and imipin and meropenem and cefepime. If the patient is allergic to lactams, then consider the use of ciprofloxacin and levofloxacin plus clindamycin. Vancomycin should be added to the each of above reasons. Reasons include imipin or meropenem or cefepime and piperacillin. Vancomycin should be added if the patient is having enveloping vascular catheter, has received pendulum prophylaxis, has received intensive chemotherapy to produce mucosal damage, if staphylococcus are suspected, if the institution has higher incidence of MRSA infection, if there is high prevalence of MRSA isolated in the community. Empirical antifungal therapy with echinocandida or lipid formation of aminotrophins should be added if the patient is hypotension and has been receiving the broad spectrum antibacterial drugs. In case of splenectomy patient, we should think of cefotaxime or ceftriaxone should be added. And in case of local prevalence for cephalosporin resistance, then think of vancomycin. If the patient is allergic to lactam drugs, then vancomycin plus moxifloxacin or ribofloxacin or azithromycin should be added. In case of AIDS patient, we should add cefepime or piperacillin plus tobramycin should be used. If the patient is allergic to lactam, then ciprofloxacin or levofloxacin plus vancomycin with tobramycin should be used. In case of IV drug abusers, vancomycin is ideal. Most patients requires antimicrobial therapy after at least for 1 week. The duration of treatment is typically influenced by various factors like site of infection, adequacy of surgical drainage, patient's underlying disease, and antimicrobial suspected of the microbial which is isolated from the culture. The absence of a microbial pathogen in the culture doesn't indicate to stop the antimicrobial therapy, since appropriate antimicrobial regimes should be beneficial in both culture negative and culture positive cases. We should remove the source of infection. The site of occult infection should be sought carefully, particularly in the lungs and abdomen and urinary tract. In case of lungs, we should look for chest X-ray and CT chest to identify the parenchymal, mediastinal, or pleural infection. In the abdomen, we should do ultrasonography, CT imaging if required to look for any evidence of cholecystitis, bile duct dilatation, or pus collection in the liver and subphrenic space or spleen. In case of urinary tract, in the patients with severe sepsis arising from the urinary tracts, sonography or CT should be used to rule out the urethral obstruction, perinephric abscess, or renal abscess, and Foley's and drainage catheters should be replaced. In invilling, IV or arterial catheter should be removed and it should be rolled over the blood agar plate for quantitative culture, and a new catheter should be inserted at different site. If the paranasal sinusitis is suspected, if the patient is in the nasal intubation, mostly it is affected by gram-negative bacteria. In case of neutropenic patients, cutaneous sites, tenderness, erythema, particularly in the perianal region, must be carefully sought. In the patients with sacral decubitus ulcer or bed sore, it is important to exclude the pelvic or soft tissue pus collection with CT or MRI. Hemodynamic and respiratory and metabolic supports. The primary goal is to supplement the adequate oxygen because the tissue is the cells are not getting the adequate oxygen perfusion, and subtract the delivery to the tissue as quickly as possible to improve the tissue oxygen utilization and cellular metabolism. And adequate organ perfusion is also essential. And circulatory adequacy is assessed by measurement of the arterial blood pressure and monitoring parameters like urinary output and skin perfusion. For circulatory adequacy, urine output is the main thing which we see in clinics. Indirect indices of oxygen delivery or and consumption, such as central venous oxygen saturation, may also be useful. Initial management of hypotension should be included in administration of IV fluids, typically beginning with 1 to 2 liters of normal saline or 1 to 2 hours. To avoid pulmonary edema, central venous pressure should be maintained between 8 to 12 centimeter of water. Urine output should be more than 0.5 ml per kg per hour. And the fluid, we should administrate fluids and diuretics like furosemide if needed. The goal is to maintain the mean arterial blood pressure of more than 65 mmHg. If these guidelines cannot be met by volume infusion and vasopressor therapy is indicated. The tighter dose of norepinephrine or dopamine should be administered through central catheter. If myocardial dysfunction produces elevated cardiac filling pressures and low cardiac output, inotrope therapy, dopamine should be recommended. If the patient is not responding with all this, then we should think of adding the hydrocortisone, which is 50 IV for 6 hours. And this hydrocortisone should be given for 5 to 7 days before, and slowly we have to taper the dose. Hydrocortisone therapy actually is not effective in septic shock. It hastens the recovery from the septic shock. Ventilatory therapy is indicated for progressive hypoxemia, hypercapnia, neurological deterioration, and respiratory muscle failure. Sustained tachypnea of respiratory rate more than 30 breaths per minute indicates the impending respiratory collapse. Hence, mechanical ventilation is often indicated to ensure adequate oxygenation to divert blood from the muzzle to respiration and prevent aspiration of oropharyngeal content and reduce the cardiac afterload. The result of recent studies favor the use of low tidal volume, 6 ml per kg in the ideal body weight and low as 4 ml per kg in the plateau pressure of which exceeds 30 centimeter water. The patients undergoing mechanical ventilation requires careful sedation, adequate elevation of the height of the bed helps to prevent the nosocomial pneumonia, and stress ulcer prophylaxis should be given by histamine H2 receptor antagonist or decreased risk of gastrointestinal hemorrhage. Erythrocyte transfusion is recommended when the blood hemoglobin level is less than 7 and the target level should be 9 in the adults, and erythropoietin should not be used in case of to treat the sepsis related anemia. In case of severe metabolic acidosis, bicarbonate should be given. In case disseminated intravascular coagulopathy, if complicated by nasal bleeding, should be treated with transfusion with fresh frozen plasma and platelets. Successful treatment of underlying infection is essential to reverse both acidosis and disseminated intravascular coagulopathy. Patients who are hypercatabolic and have acute renal failure may benefit greatly with intermittent hemodialysis. General supports. If the patient with prolonged severe sepsis is lasting for more than 3 to 4 days, we should think of nutritional supplement to reduce the impact of protein hypercatabolism. In the show the proteins will be utilized, so we should supplement them. The available evidence favors the entered delivery route. The prophylaxis, we should also think of DVT prophylaxis because the patient will be bedridden and there is a high chance of DVT. So we should give prophylactic heparin. Recovery is assisted by the prevention of skin breakdowns and nosocomial infection and stress ulcers. Most experts now recommend using the insulin to maintain the blood glucose concentration should be maintained less than 150. In case of severe sepsis, the patient's sugars will be raised, so insulin should be given and we should maintain the sugars below 150. Patients receive intravenous insulin monitored frequently every 1 to 2 hours to prevent hypoglycemia. Surviving sepsis campaign funding. What we should be done within 3 hours, measure lactate levels and obtain the blood cultures prior to the administration of antibiotics. Because after antibiotic, there is a high chance that we will get the culture negative. Blood sample should be collected from at least two sites. The right and left brachial is preferred. And administration of broad spectrum antibiotics should, after culture, we should change this broad spectrum antibiotics according to the culture sensitivity. And administration of 30 ml per kg crystalloids and hypotension and lactate more than 4 milligram per liter. No, to be complete within 6 hours. Apply vasopressor for hypotension that does not respond to the fluid resuscitation to mean arterial pressure of 65 mmHg. In the event of persistent arterial hypotension despite volume resuscitation, initial lactates of 4 millimoles per liter. Measure central venous pressure and measure central venous oxygen saturation. Remeasure lactates if initial lactate was elevated. Prognosis. Most of the patient, 20 to 35% patient with severe sepsis and 40 to 60% patients with septic shock die within 30 days. Other die ensuing 6 months. Late death often because of poor control infection, immunosuppression, complications of intensive care, and failure of multiple organs of patient's underlying disease. Age and prior health status are also important risk factors. And the individuals with pre-existing comorbidities are at a greater risk of dying with severe sepsis at any age. How can we prevent this? Most episodes of severe septic and sepsis shock complications of nosocomial infection. This might be prevented by reducing the number of invasive procedures undertaken and limiting the use of inbuilt vascular and bladder catheterization and reducing the incidence and duration of prolonged neutropenia. More aggressively treating localized nosocomial infection and indiscriminate use of antimicrobial agents and glucocorticosteroids should be avoided. Thank you. Any doubts?